So I've largely based this talk around the framework of this instructional course lectures article from this year, talking about the surgical management of active hip pain. And essentially I've done this in two forms, talking at two different types of pre-arthritic or hip pain. And it's talking about dysplasia and the mechanisms to treat that, be it preservation of salvage procedures, impingement, which may or may not be the result of paediatric hip conditions, both of these leading to end-stage osteoarthritis requiring arthroplasty. So I'll talk about adult DDH first, and this is what we'd all know as a shallow socket disease. It's not common anymore in Australia, in our population, because of such good screening that we have in early childhood here in Australia, but there's still quite a large immigrant population that might have undiagnosed hips or unscreened hips arriving on our shores. We would normally see it as either mild forms of it, where it's not diagnosed early in life and not treated and becoming painful in the young adult, or severe in someone who has Crow-4 and dislocations like that lady that we put up recently for, at the start of the term with the bilateral hip dislocations. And so what we're most likely to see in a young lady with a painful hip is a new presentation of a mild hip dysplasia. It's most likely to be the left hip in the first child of a Mediterranean family that was born breech and swaddled as a child. The pain that they get is normally in the groin, but it can be in the back. And it's not. It's from usually third decade, so mid-20s onwards, that these things start to happen as the point loading on the edge of the acetabulum starts to increase. And it might not be present with degenerate changes. So like all things in clinic, we'd start off getting an AP pelvis and maybe a lateral, but if we're going to be characterising DDH, we'll specifically start looking at special views, and the false profile is one that we use in the talk. A CT scan is useful for the three-dimensional modelling and help characterise the degree of coverage on the front of the acetabulum, which is hard to do on a plain film. MRI scan will tell you about the chondral surfaces, the size of the labrum, and any other subsequent damage around there. This is a plain AP radiograph of someone with hip dysplasia. You can see it's worse on the left. So things that we would measure on this start off with one that most people would know, the center edge angle of Wiberg, and that's the angle taken to the edge of the lateral sawsill, being sure that you don't take the edge of an osteophyte or a calcified labrum from the vertical line at the center of the radius of the hip. Sharp angle is another one, measuring from the inferior teardrop across the front of the acetabulum. The tinus angle is looking at the angle of the sawsill itself. It's the slightly sclerotic area underneath the weight-bearing cartilage on the top of the acetabulum. Sawsill is a French word for eyebrow, and you get that picture. That's what it looks like. So false profile is a view that we take when the patient is 65 degrees to the horizontal, and it's looking at the coverage on the front of the acetabulum. You can see from the diagram it looks straight down the femoral neck as opposed to a true lateral of the hip, which might have a bit of anteversion built in. And we can measure on that the centre edge angle of Lecain. It's the anterior coverage. With the centre edge angles, we say normal is about 25 degrees or greater. This particular person doesn't have anterior coverage deficit, but the film we showed earlier, you could see quite a degree of uncoverage laterally. So who can be treated early for this and try and prevent total hips? People with congruent hip joints might be the ones who are suitable for the redirectional osteotomies. But if you have an incongruent joint and have a slight degree of dislocation, you may be a candidate for a salvage procedure, which relies on having an intact capsule and intact labrum. And the aim, as in most of the procedures I'm going to talk about, is to try and prevent progression to total hip replacement if we can. The redirectional procedures we'll start off with what we call a single anonymous osteotomy, so through the pelvic bone running from the anterior to the posterior column above the acetabulum. And the Salvage osteotomy is essentially an opening wedge of the pelvis. You rely on hinging at the pubic symphysis. You take a wedge out of bone above the acetabulum and lateralise the whole acetabulum. From there you can add further osteotomies to your single osteotomy, a double being a hop or a Sutherland, where it's through the pubis, or a triple, such as a steel or a tonus, where you take them through the posterior column as well as through the acetabulum, and here's a few basic details. But the one that's performed mostly now is a Ganz or Bernese osteotomy, and it's what we would know as a PAO, periacetabular osteotomy. This has its advantages because it's done through a single incision, whereas some of the other triples are done through two incisions. It leaves the posterior column intact, which theoretically provides a benefit for rehab when you don't disrupt the pelvic integrity. the aperture remains constant. Some of the others where you medialise or lateralise, you end up with a smaller aperture in the pelvis. And women of childbearing age who are the ones who are most likely to present with this procedure, that's not ideal. And you can achieve a very large correction. You can take someone with a congruent hip with very little coverage and bring that around again. But on the downside, it's a very difficult operation. It's not common. Those people who do them wouldn't do that many in the year. And it is a very large incision. It's associated with more hip mobility, and it does have a very slow rehab. But when faced with the option of vertical coated hip, it's something that some people would argue for. Here's a diagram of a Ganz osteotomy. You can see the cut from the AIIS across the top of the acetabulum, down through the posterior column, and then into the foramen, and then the front, through the front of the acetabulum, through the Bewsher. This is an X-ray of someone who's undergone bilateral Ganz osteotomies. You can see, compared to the preoperative X-ray on the top left, there's a greater coverage of the acetabulum with redirection. Salvage procedures are ones where you have either too much degenerate change already through the cartilage on the top of the acetabulum, or you have an incongruent hip. And these are operations where you're trying to achieve metaplasia of the intact capsule and labrum by providing bony architecture above. And the two that we'd see most are Chiari or shelf acetabuloplasty. And Chiari is essentially a reverse salter. It's medialising the acetabulum and leaving a piece of ilium above to provide weight-bearing support to the soft tissues above the hip. This is a post-operative radiograph. You can see the degree of medialisation. And the shelf acetabuloplasty. This is, I'm afraid, not a particularly good diagram, but it's taking a wedge, a iliac crest, and placing it in the table above the acetabulum to try and again provide the metaplasia. And here's a radiograph of someone who's undergone shelf, and you can see on the right side there's quite a large area of metaplasia. The capsule looks like it's an acetabulum now on the top. So are these successful? Well, no one really knows, because there's no studies that pits osteotomy against nothing. And it's very difficult to say how one person would have behaved if they had had an osteotomy. And we're not sure if the problem is total hip replacement. What we do know is that people who have symptomatic pain before their osteotomy often, if they're the right patients, get a good increase in the hip scores afterwards. There are some very clear predictors of failure, however. Advancing age, degeneration of the cartilage, and if you happen to miss some incongruence, and these are things that will generate poor outcomes. There's a paper from 2011, JBJ, is talking about this. If you have none of these factors, then 14% is your adverse outcome. In this paper, this 14% he had was total hip replacement at about 6 years post-osteotomy. One predictor was 36%, and two predictors was 95% chance of a not good outcome as a result. So, in short, do osteotomies work? Yes, if you've got a symptomatic hip complications. Talk about FAI now. It's the second cause of pre-arthritic hips in young patients, and that's impingement, as the name suggests, between the femoral head and the acetabulum. We talk about this in two ways, being cam impingement, where the femoral head's the incongruent part of the equation, or pincer, which is where there's over-coverage of the acetabulum, and even though the femoral head's still congruent, it impinges in extreme internal rotation. This is becoming increasingly diagnosed amongst our population as we understand the condition more, and we can show that it does initially lead to labral pathology and cartilage delamination of the acetabulum, and will lead to OA if it's untreated. This can also be present in people who have previous SUFI or Perthes disease, but I'm not going to talk about them so much at this point. This is some diagrams. Normal hip showing a congruent hip joint and a radius that's constant around the femoral head. This is a diagram showing a cam lesion where the radius increases anteriorly, and you can imagine if that was internally rotated, that shaded area would butt up against the acetabulum. Pincer impingement, there's overgrowth of the anterior part of the acetabulum, and you can see that might interfere or combined, and that's something that some series would suggest up to 50% of sufferers of FAI would have. The cam lesions would often present in the second to fourth decade, so people within their teens up through to their mid-30s. It's got a propensity towards males, and it's thought to be partly genetic, but also possibly stress loading on the physes as it's closing from high energy activities such as playing football that we do in Australia. Whereas pincer is more likely to be either in the third decade of life or very early, and it's more likely to be in females rather than males. And this can also be due to a retroverted acetabulum or a cox profunda that you might get with various hips. Both these will present as groin pain on flexion and internal rotation. If you've stirred up the labrum enough, then it might present as groin pain in the activities of daily life. When on X-ray, you might not see any clear degeneration. So, like all things, we start with some plain images in our clinic, AP, and if you're going to get a lateral of the hip, a done view is the most useful. And that's a true lateral of the femoral neck as opposed to a lateral of the hip. CT scans are useful quite truthfully mostly in 3D reconstructions because it's easier to understand. But if you're going to have the slices, then it needs to be reformatted in a coronal and sagittal oblique, which is orthogonal to the femoral head, femoral neck, and gives us a better view. MRI scan, with or without arthrogram, is useful because it tells you the condition of the cartilage inside the acetabulum still and whether or not there's a labral tear. So here's some plain films, an AP and a done view. You can see this picture on the left, it's an AP pelvis. The right hip more than the left has got the cam lesion, which is visible about 1.5 centimetres lateral to the edge of the lateral psoas. And the lateral view, you can see there's an enormous cam lesion anteriorly there. This is a film that tries to demonstrate a crossover sign of a retroverted acetabulum. The anterior wall of the acetabulum's got more of a wave to it, and on the unmarked side you can make that out crossing over the posterior wall of the acetabulum, which is a straight line. We can work from the plain films out what the alpha angle is, and that's the angle where the subtended from the axis of the femoral neck and where the radius of the femoral head leaves the circle that you subtend. It could be done on an AP or a lateral film. This is a CT scan that demonstrates quite nicely a very large cam lesion anteriorly and superiorly on the femoral neck. An MRI such as this can show that there's chondral damage and a labral detachment. So, who can be treated early and prevent total hip replacement? And again, patients without too much degeneration. You can take away the bony lesion that's causing the impingement with cam or tensor lesions. Labral tears can be repaired, and if you've got chondral damage, you can either resect it, debride it, reattach it, or microfracture in an attempt. There have been, I think there's a use fibre and glue to reattach cartilage that delaminates further around the roof, but it's not yet known whether it's successful. These can be done through either open or arthroscopic procedures. And once again, the aim is to delay total hip as long as possible. Talk about open procedures first. That's done through a surgical dislocation. It gives you great vision because you get to see the whole femoral head through a anterolateral approach, a Watson-Jones approach, interval between TFL and fascia lata, trochanteric flip to provide the adductors moving forward and bring the femoral head out through the front of the acetabulum. It gives you access to the whole head. You can get underneath it. You can get right the way around the acetabulum, fix labral tears anywhere. But it does have its downsides. It's invasive. It's often associated with large amounts of blood loss. It takes a long time to get over. You can often get problems with union of your trochanteric flip. The hardware itself becomes irritating underneath the trochanteric bursa. And the big one that the hip arthroscopists talk about is you have to sacrifice the ligament teres. But here's a diagram of an open dislocation. On the left, you can see that's quite a large cam lesion, and that would be very difficult to address arthroscopically. On the left side, you see there's correction. On the right side, there's a radiograph post-operatively, and you can understand how those screws holding the trochanteric flip back on might cause irritation of trochanteric bursa, and they often get removed as a subsequent procedure. The hip arthroscopy, on the other hand, it's a minimally invasive procedure. It gives you excellent vision of what you are trying to see, and it's much shorter rehab. It can be done as an outpatient. People get up and walking that day. But there are downsides. You can't get inferiorly or posteriorly on the femoral neck. You possibly remove too much bone when you're using a reamer through a portal. We'd all know through experience with shoulders that sometimes you can slip and push the burr in a little bit too far, and it's very difficult to contour it. Whereas an open dislocation, you can use a template to show how much bone you need to remove. And there is morbidity associated with traction, although it's not common. You can cause pudendal nerve palsies, you can cause lateral femoral cutaneous nerve palsies from blindly placing anterior portals too anteriorly. There's a theoretical risk of AVN, although I don't think there's any actual recorded cases as a result. And if you're removing too much bone, you can theoretically cause fracture as well. Here's a picture demonstrating a labral repair and osteotomy on the femoral head, and you get excellent vision, as you can see. And by moving in real time the hip, you can see just where you need to remove the bone if you've got enough gone. So is it successful? Well, again, there's no studies pitting one against the other, and there's no studies pitting either of these against non-operatively, but it's quite difficult to say if you treat one hip with operation and another without, what would the natural history have been of each of those conditions? And we don't know if it belongs to total hip replacement. But again, what we do know is that people who are symptomatic and appropriate candidates are going to get adequate pain relief of around 20 points in the Harris hip score as a result of their operation. Both methods will lead to a significant increase in high function. People who play sport, there's a paper from the new American Journal of Sports Medicine in 2011 saying 90% of a series return to playing professional ice hockey after their open dislocations. And again, Arthroscopy Journal looking at 3.5 years post hip arthroscopy returning to high function. But there's a very clear set of things that cause poor outcomes, which are if you correct the soft tissue, such as a labral tear, and don't address completely the cam lesion, you'll have a poor outcome. If you have pre-existing chondral damage that's too extensive to address, you'll have a poor outcome. And if you debride rather than reattach the labrum when it's quite tatty, then again that's associated with poor outcome. So in short, people who undergo operations for FAI need to have symptomatic hips without too much degeneration. And like all things in orthopedics, the surgeon needs to be experienced because it's quite a difficult operation and the complications are more likely to occur early in the surgeon's experience. Which brings us to end-stage arthritis, which is what happens when either of these things fail. This is an enormous topic. I'll touch briefly on it, but I think it's best talked about in a separate talk, which I'm happy to give later. And what we know and what we've talked about recently with our case comments is that the symptoms should dictate the time that we go to arthroplasty. There's no point having somebody who's very young languishing with debilitating pain at home and not being able to contribute to society. We do know that the economic costs of not operating are very high. People have welfare, they're unemployed, and their healthcare costs become enormous. And we do know that patients who do have hip replacements early do return to work and do return to high function. 90% in this particular article from 2007. But it's fraught with questions that need to be answered, and this is something, as I said, it's quite a large topic. Resurfacing versus total hip is an argument that's possibly almost settled, but a recent paper, 2011, suggested that in appropriate candidates, resurfacing patients had higher activity-based scores in their post-operative scores compared to total hip replacement. And it only works well in males with large femoral heads. Mini versus traditional stems is not a topic that's yet decided. Cemented versus uncemented is the Europe versus America argument. If you are going to use uncemented stems, do you use a fit and fill or a French paradox? Carai is very popular in Australia and does very well, but the stem that does best in the Australian Joint Replacement Registry is a fit and fill. Do you use a big or a small head? Big heads provide stability but have larger volumetric wear. Small heads, less stability, but recent data would suggest have produced wear particles in poly heads. Metal on poly versus ceramic, again, is not becoming clear with the advent of oxinium heads, oxidized aluminium zirconium, and the high-linked poly, whether or not it's going to last as long as ceramic and whether it has the same consequences if there's dislocation, is still not a settled argument. So that's something that I think we should address in a separate talk that will go into detail about that. So in summary, adults with hip pain from either FAI or from very mild acetabuloplasty can be treated as long as that you have symptomology without having too much degeneration and a good surgeon, because we know that the learning curve is quite long and people who are early in their experience are more likely to provide an outcome with complications. And no one knows if we can make total hips last longer. But young people do have total hips pretty well.